complications that's been in the news big lately has been Barrett's esophagus. This is another term you're going to hear a lot and see a lot in the next couple of years. Barrett's esophagus is a fixed change in a portion of the lining of the esophagus that's not supposed to be there. It's new lining. It's called metaplastic lining in our terminology. It is more resistant to acid injury, and in fact, many patients who develop Barrett's esophagus will actually tell you, my symptoms are getting better, because Barrett's is a modified lining that looks a little more like stomach lining, that has a little bit more acid resistance. Barrett's is found in about 10 to 15% of patients with erosive esophagitis at the time of diagnosis. It's found in 40% of patients with peptic esophageal strictures. So it's very common. It's 3 to 1 more common in men than women. The prevalence of Barrett's seems to increase with age. The prevalence also increases with the duration of patients' reflux or heartburn symptoms. In itself, Barrett's is not a symptomatic condition. Reflux is your symptomatic condition. GERD is your symptomatic condition. The biggest danger of Barrett's esophagus is the increased cancer risk. The cancer risk in patients with Barrett's is 40 to 50 times higher than that of the general population. Now, Barrett's doesn't become Barrett's to cancer. Barrett's can undergo a series of changes, and it's a series of changes called dysplasia. So you can look for cancer. You can look for changes that approach that. I tell my women patients it's very analogous to doing pap smears on the cervix and looking for early signs. We, in essence, when we survey Barrett's, do pap smears of the esophagus. That's what we're looking for, signs of dysplasia. Atypical changes within these cells that tell us something's happening. We're getting into a transitional stage. Most of the cancers we find today in the United States in the esophagus arise within Barrett's, and that's new. That wasn't the case probably 30 or 40 years ago. Esophageal cancer, just to bring up a point, the incidence of esophageal cancer in the last 30 years is rising faster than any other cancer in this country. Some other complications, dental problems, not uncommon. Poor dentition, gingivitis, gum disease, asthma, asthmatic bronchitis, chronic cough, chronic obstructive lung disease, all have been linked to gastroesophageal reflux. Aspiration. We've had patients come in with frank aspiration pneumonia, where the contents goes right down into their lungs. It can happen while you're sleeping. It can happen while you're awake. And it can actually cause a very severe pneumonia because it can be multiple organisms that cause that pneumonia. Let's go over treatment strategies quick, and I'm not going to take up a lot of your time here. Treatment strategies in reflux historically have centered around two approaches. One is the step-up, and one is the step-in approach. Step-up approach means you start with the easy things and you work your way up until you achieve good symptomatic relief. Step-in means you hit it hard. Most patients, frankly, that come into my office, we tend, as gastroenterologists, to step in because we want the patients to feel better right away. And we achieve that, then we try to wean down or taper if we get success. But for purposes of this discussion, I think it's worthwhile to go over a step-up approach so you can learn what you can do for yourself without even seeing a physician to manage reflux symptoms. Let's see. This is the reaction I usually get when I tell people to change their lifestyle. Lifestyle modification is part of treating reflux disease. It's phase 1 of the step-up approach of reflux. And a lot of lifestyle modification is centered around diet modification. There's a lot of instruction that goes into managing it that I give my patients. But if you know this, you can recognize that a lot of people find out for themselves. We encourage the use of small meals. We encourage people to eat slowly. Overdistension of the stomach has clearly been shown to cause frequent transient relaxation of the sphincter muscle between the food pipe and the stomach. We tell people to decrease the fat content of their meals. Fat has the same effect. And then there's certain specific food items that tend to be a problem. Tomato-based products, citrus, mints, especially peppermint, and coffee, caffeine. These things all can have effects on the lower esophageal sphincter muscle. Weight reduction, we encourage. It seems weight reduction does a lot, but they've done studies to actually look at that, where they've had obese patients lose a lot of weight, and their reflux that had reflux, and the reflux didn't necessarily go away, so it's not the only factor involved. We encourage people to stop smoking, to decrease alcohol intake. We encourage people, especially who have nighttime reflux symptoms, to elevate the head of their bed. I tell my patients